Hello there, how do you do fellow kids? I'm Tony Meekum, and today we're going to talk about temporomandibular disorders and orofacial pain. This has a reputation for being really complicated. Now it can be, but hopefully I can get you to the point where you feel like you can treat a majority of the basic cases of this, and for the ones that are more complicated, then refer them. So almost all the diagnosis happens in the history. Remember that important point. Imaging confirms. So we'll cover anatomy first and then how to take the history, then get to diagnosis and just very briefly on treatment. So I do use a lot of references on this, the images, a lot of them I look at White and Farrell, our radiology text. And then of all these different references, I actually like the Contemporary Oral and Maxillofacial Surgery book. I feel like it really simplified the diagnosis for at least the most common presentations of the disorder. And so what you need to know about TMD, temporomandibular disorders, it's kind of broadly defined as a group of musculoskeletal and neuromuscular conditions that involve the temporomandibular joints, masculatory muscles. So that's not very specific, is it? And you talk to different specialists, they seem to be telling a different story. You read those different books, it's almost like they speak different languages and no standard of classification. In a lot of cases, that leaves us feeling like this. And this is why a lot of general dentists don't like to treat this. But like I said, at the end of this, hopefully you're at least comfortable asking those questions, trying to dig into the history. And if it's a simple case to treat, maybe you can treat a lot of these cases. All right, so there are different classifications of orofacial pain. Majority of what we'll be able to treat in the dental world is somatic. That's like our temporomandibular joint disorders, periodontal disease, dental disease, things that cause actual physical pain. And then there's neuropathic pain or damage to nerves, nerve pathways, nerve damage or stroke. And then there's psychological. That's going to be really rare, so much so that we'll probably not cover it here. But remember, we will talk about a psychological component to this because there's always a psychological component to pain, even if that's not the primary source. And so breaking that out even more detailed, under somatic, we have our big three: myofascial pain, disc derangement, and arthritis. I think that covers a majority of the disease that you're going to see, and you can get to a point where you're going to be able to treat a majority of these. And then we also have infection and tumor, which are a little more rare. Then our neuropathic conditions, we'll talk a bit about neuralgias, specifically trigeminal neuralgia. And then headaches is another cause that I'm not really going to get into in this lecture right now. I'm going to do a little more detailed dive into pain, orofacial pain, when we do a seminar in your oral pathology OSCE seminar. So that's going to come up during your third year. So look forward to that one. And so what do you do when a patient comes in, they're holding their jaw, they say, I think I have TMJ. You ever heard that before? And so immediately you should start probing, start digging questions. You can rule out typical dental disease with your imaging. We can rule out a majority of those typical things that we see. But if it's not any of those common things, then start digging into the patient history and see if you can really nail down what's causing it. And that's the whole point of today. So I realize this font isn't that accessible. On the next slide, we have all the same text if you want to read it there. But this is just kind of pointing out the mystery is in the history. Typical symptoms are going to be pain in the joint or the ear or muscles, anything in the immediate area, headache, joint stiffness, reduced motion, clicking or other noises, locking, subluxation, changes in occlusion, all those lead to TMJ symptoms. And then I do think the type of pain, as well as the location, can really help you narrow down which of these it might be coming from. Myofascial disorders, more directly in the pain of muscles mastication, may be related to headache. Disc derangement is when you have that clicking or popping right in the joint, reduced range of motion in some cases. Arthritis is going to be more of a crepitus, so kind of that crackling sensation, crackling noise, pain right over the joint itself. A neoplasm, there's going to be a swelling of the joint, usually less painful unless it does start to interfere with function, and that's going to be slowly growing. Inflammatory lesion, remember those cardinal signs of inflammation we talked about: redness, heat, swelling, intense pain. In some cases, you might see a sign of infection and inflammation around it. All right, quick anatomy review. We're going to go through the glenoid fossa, or sometimes called the mandibular fossa. I never like glenoid because I think you're talking about the shoulder. That's what they typically refer to as the glenoid fossa, but we can call it that. And the articular eminence, of course, the condyle, the fibrocartilage, articular disc, and then the tissues inside the joint space behind the disc we'll call retrodiscal tissues. And that has a capsule aligning the whole joint, and that's aligned with synovial membrane. Ligaments and muscles, of course, which provide movement. So let's get a little more detailed view of the mandibular condyle. It's typically cylindrical, round on the top, about 2 centimeters in the medial lateral dimension. Variable in shape though. What these images here show you is the normal anatomical variation in shape. Sometimes really flat. Actually, that one's flatter. Sometimes more curved and round. Sometimes kind of heart-shaped. And this is all just normal anatomical variation. And it's not angled perfectly 90 degrees to your sagittal plane. It's more at a 15 to 33 degree angle with that plane. And so this just has labeled the medial pole, the lateral pole, the pterygoid fovea, because that's where the pterygoid muscles attach. And so these are some CBCTs showing normal variation. This looks like a sagittal view, and you can see a nice well-defined outline. Maybe it's a little bit flattened there, but is that just normal variation, physiological remodeling? It could be. This is nice and round. This looks like potentially a younger patient. Yeah, this is a 7-year-old, and they don't have that established cortex like we saw over here. And that's perfectly normal for a young patient. If this were an older patient, you'd be wondering where the cortex went, and is it a sign of disease? But remember that image. It's normal for a young patient. This shows a variation in the mastoid air cells. What are we looking at here? Glenoid fossa, condyle. This is the articular eminence. This is anterior in this image. And this is the external auditory canal. So this is pointing out some mastoid air cells that have pneumatized almost in, or actually into the articular eminence. You'll see that in cases. Sometimes that'll show up in a panoramic radiograph. And what do you need to know about the articular disc, the meniscus? This is avascular. It's a very dense fibrous connective tissue disc, and it divides the joint cavity into two, the superior and the inferior. It's going to be biconcave in shape so that it can stay in close proximity to the condyle as the condyle moves. So the condyle can rotate, and the condyle can also translate, if you remember that movement of the mandibular condyle. And the disc in health should always stay right against that articular surface of the condyle. And so the anterior band is thicker and the posterior band is thicker, very thick posterior band. And that's what keeps it right against the condyle, even as the condyle moves. Disc moves forward, so maintaining a thin portion between the condylar head and articular eminence. So this usually stays really thin. And the disc actually does attach to the condylar poles, both on the medial and lateral ends. Then what do you need to know about retrodiscal tissues, or these tissues behind the disc? And so this has flexible tissue that has loose vascular tissue. It can be very vascularized. There's also nerve bundles in here, so this can be sensitive. If the disc starts slipping out of place and the patient starts occluding on those retrodiscal tissues, initially that can be really sensitive. Over time, it can kind of harden and form what's called a pseudodisc. But this flexible tissue is what allows that disc to move forward and back. It allows a lot of that, well, mainly that translation movement of the joint. Here, those images just kind of shown together. This one was our sagittal one that we just saw in the last slide, and this cadaver section showing the same thing. So the disc here, the articular eminence, the posterior attachment, mandibular condyle. This actually shows the LPM. What's that? That's the lateral pterygoid muscle as it attaches to that anterior border of the condyle. All right, and I talked about the condylar movement, but usually about the first 20 millimeters, meaning anterior opening, 20 millimeters, your disc is just rotating. And you can kind of feel that in your own joint. Open just about 20 millimeters and your joint, your jaw doesn't really have to slide forward. I got a little pop there. But as you do open wider, you have to translate. And that rotation occurs in the inferior compartment, meaning the mandible is rotating like this against the disc, and the disc is staying in place. And then translation, I said the disc stays roughly in the same position against the mandibular condyle. So as it rotates, now we need to do our articular eminence. As it translates, then the disc slides with the condyle. And so that's what it means by the translation occurring in the superior compartment. And so this shows a radiograph of the joint closed. See how it's nicely seated in the glenoid fossa. There's just a normal thickness of space where you can imagine a healthy disc fitting in there. And then the patient translates anterior. This looks a little bit hypermobile, so it should be within 5 millimeters of the crest of the articular eminence. So that's just about at that limit, almost to the point where you're going to call this hypermobility. In most cases, it just goes to that 12 o'clock position. Say this is the articular eminence. The mandibular condyle usually comes just like this, just to that crest of the articular eminence. And this is just an anatomical variant to know Bifid condyle. I showed you some of those examples where some of those condyles tended to be heart-shaped. This is just a more exaggerated variant of that, where there's this depression or notch in the superior condylar surface. So don't always assume that's disease if you see that. These have nice, well-defined, smooth outlines. In most cases like that, when it maintains that cortical outline, that's just normal anatomical variation. And I think you can really distinguish it from a vertical condylar fracture, because a condylar fracture isn't going to have those smooth corticated borders. Also probably history, also probably they'll be in pain. All right, so what all is involved in your patient examination? Well, the interview, you got to get the health history, right? In most cases, you're going to start with a panoramic radiograph. Now, I could talk about dose and talk about how in a lot of our CBCTs, the doses come down, where it might make sense to do a CBCT because you get even more information for similar or maybe a little bit more dose. And so why not save them that dose from the panoramic? But that's maybe beyond the topic of this lecture. You're going to do muscle and joint palpation, and that's going to tell you different things. The range of motion evaluation. Always do a psychological evaluation in patients with TMD. That's not saying every patient that has this is crazy, but if ever someone is in chronic pain, there's going to be a degree of psychological component. And at the least you want to rule out psychological distress. And only after all that are you going to have your initial diagnosis and treatment plan. All right, so here's what takes place in the interview. First of all, we all know, get your chief complaint, right? And then sometimes we talk about SOAP notes. Chief complaint is your subjective. Some of these things will fit in subjective and some more objective as we do the test. Now, I used to use a different acronym, but I want to stay true to our school, and Dr. Miller uses this for surgery. So I'm going to start teaching the same acronym, which is LOCATES. L for the location, O for onset. Is it sudden or gradual? What were you doing when it happened? C is for character. That's a really important one. Don't overlook this one. Is it sharp, dull, achy, burning? And I'll tell you what each of those mean. A for aggravating or alleviating. What makes it better or worse? T, and this is a really important one for a lot of these concepts that we're teaching today, is the timing. Is it worse in the morning or worse at night? Is it constant or intermittent? Do you notice a pattern? Is it episodic and it comes and goes? And then E is going to be, you could think of a couple things. Effect on function, right? Is it affecting how you function? Or does it radiate to some external site? And then the S, of course, is for severity. 0 to 10. Of course, you have to explain to some patients that say, oh yeah, I'm in 10 out of 10 pain, and they look just happy as a clam. Well, 10 out of 10 pain means you're burning on fire. Your entire body's on fire. So are you really 10 out of 10? And they might change and say, well, okay, 9.8. But anyway, that's your severity scale. And then impact on daily life. Oh, here's a nice video I wanted to show you. And so this is from Tommy Boy, an example of how not to listen to your patients. And so Tommy Boy here, Chris Farley, is talking to David Spade, and he says he thinks he might have a mark there. And he's asking him, is there a mark? And he really points out, he does a great job as a patient. This is what you just want, exactly what you want him to do. Point with one finger where the pain is. And he does that. And we'll look at David Spade's response here.
My shoulder doesn't hurt very much, but my face does. Right here. Not here or here so much, but right here.
Nope. Ship shape.
All right, so what's the point of that? Yeah, be a better listener than David Spade was, right? We're going to actually listen to patients. All right, we're going to take their concerns seriously. And we also need to look at any past medical history, because a lot of these things we may not even think of could be affecting their pain condition. Any past serious illness, hospitalization, operations, medications, any significant treatments, any systemic condition, osteoarthritis, rheumatoid arthritis, and we're going to rule out some of that with our imaging, autoimmune diseases, connective tissue. So discuss with the patient's physician as needed. Review of all the systems, right? Go through the different systems, cardiovascular, digestive, renal, liver, peripheral, central nervous system. Determine if there's any relationship to chief complaint, and they may need a further workup and a referral to a physician for further evaluation. All right, this is one we mean by character of pain, whether it's dull or achy, sharp or shooting. And not everything's going to be cut and dry, but for testing purposes, I'm going to try to make it pretty self-explanatory. And these can lead you to the right direction. So if it's a dull or achy pain, especially if it's localized to the muscles of mastication, more of a muscular pain. Then we'll talk about our myofascial diagnoses. If it's a sharp or shooting, sharp usually means right in the point. They can really localize it right in the joint. That's more of a joint thing. If it's a shooting, a radiating pain, lancinating pain, then that's more of a nerve issue. And then we said the rating of pain, severity on a level of 1 to 10. The timing, remember that's part of our locates. Is it primarily in the morning? So off the top of your mind, you know, rheumatoid arthritis versus osteoarthritis. Which one is more common in the morning? That's rheumatoid, where osteoarthritis is more diffuse, more like the end of the day. That's when it starts hurting them. What about myofascial pain from nocturnal bruxism? That's a common one. And that's going to be more painful in the morning, but then the difference is the location, right? Located in the muscles of mastication. Oh, and here's our osteoarthritis. I already said that, by end of day. You can see how just these few things from the patient history are already directing you toward an initial diagnosis. Of course, we're going to do our imaging. We're going to do the complete patient evaluation and put everything together. But you can see how, for the most part, you're able to kind of get an idea of what's going on, I would say, for a majority of patients. So during stressful times, is it a parafunctional habit? Is it only at work? Do they get really stressed certain times of year? Is it associated with any parafunctional habit, nail biting, chewing on a pen, chewing on any item? In some cases, I knew a swimmer that his jaw would really hurt when he swam because you're swimming, you try to breathe out the side of your mouth and it's not that great on your jaw. Or sometimes in my case, I chew too much gum in some days and that can lead to pain. So you can really nail down what's causing or what may be causing their pain. As far as imaging modality, we said panoramic is good for screening, rules out gross disease. Sometimes it's all required. If the joints look completely healthy, you've probably ruled out at least significant osteoarthritis. You've ruled out probably any tumor that's causing their symptoms. And so in some cases, that's all that's needed. But you don't really have information about condylar position or function. And mild degenerative changes might be obscured. CBCT, we know an advantage is that it's undistorted. It's relatively low dose compared to medical CT. Most cases it's higher dose than panoramic, but as I was saying, some of those doses have come down and we can do a low dose setting CBCT for roughly the same dose in a panoramic, depending on your machine, depending on your settings. And it is really good for osseous changes. Now, instead of things being hidden behind overlap of the articular eminence or part of the glenoid fossa, now we can really, in 3 dimensions, visualize those structures. And you can see even subtle changes of degenerative joint disease. But there's no soft tissue visualization. If we go on to medical CT, there's a little bit additional information from CBCT, particularly of the soft tissues. An example of that would be a neoplasm and how far it's extended into soft tissues outside of the osseous structures. You might see that better on a medical CT, but you still can't visualize the disc on an MDCT. And it's a higher dose than CBCT. If you really want to see the disc, the only thing that's going to do that is your MRI. There's no ionizing radiation, so that's a plus. And so you can actually see the disc. You can see contrast of where the disc is from other structures. You may see joint effusion. So when there's fluid inside the joint, that's a sign of infection. But there's lower detail of osseous structure. So there's kind of a good complementary trade-off between CBCT and MRI. Why don't we do more MRIs? Well, they are expensive. They're time intensive. They're hard to get into. And so those have kind of gone out of style. But in some cases, you may have a patient that needs an MRI to really diagnose what's going on in those soft tissues. All right, and this shows how TMJ imaging is typically reconstructed in our software. We're not going to just look at the strict coronal and then the strict sagittal, but it's broken out to where instead of a true sagittal, it's at 90 degrees to the condyle. I said this was a little bit, 15 to 30 degrees off from the sagittal plane. And so you want to be at 90 degrees from that to get a good view of the condyle. And if you want a good coronal view, it's really an oblique coronal view that's rotated a little bit inward from the lateral. And that goes from the medial to the lateral pole. And this gives you your best view of the outlines of the condyle. And then usually what you'll see is multiple sagittal sections. So you can see them lined up, or you can scroll through in order to see all the surfaces of the joint. And this is what that looks like. Here we have our axial slice. These are our oblique coronal slices that are going through the medial and lateral poles of the condyle, showing the outlines of the condyle. And then here's our 90 degrees or cross-sectional images. It looks like these are in 2.5 millimeter increments, so they're 2.5 millimeters apart. But we can see from the medial here to the lateral. And what do we notice in this? We notice these little cookie bites out of the top surface. When you see this little cookie bite, that's an erosion off the top surface of your mandibular condyle, or whatever joint it may be. It's the same signs that you look for. So we'll get back to some of that imaging. I'll show you more examples of degenerative joint disease.